Iron deficiency is the most common anemia around the world. And so, in order to prevent or treat iron deficiency anemia, people are given iron. They are actually instructed as to what are good sources of iron in the foods that we eat, because obviously we have dietary sources of iron. Meats, some vegetables, and grains are quite relatively high in iron. The dietary iron needs to be processed, if you want to call it that, or converted by gastric juices into an absorbable form before it is absorbed. And most often, people who have iron deficiency anemia are given iron supplements. So supplemental iron can be given as a alone in iron tablets, or it can be included in a multivitamin preparation. The oral iron preparations that are ordered for people with anemia are delivered in the form of ferrous salts, like ferrous fumarate, ferrous gluconate, ferrous sulfate. There are parenteral or injectable preparations of iron as well, several of them. We will talk about a couple, one that has a little higher risk and one that has a little lower risk when they are given parenterally. Specifically, we'll talk about iron dextran, the first in the list, or ferric gluconate, the third in the list. Um, so prevention and treatment of iron deficiency anemia is the whole reason why somebody is given iron. And it's important to note that that will treat the anemia in that it will restore adequate iron stores in the body so that normal red blood cell production can proceed. But the provider needs to investigate what's causing the anemia in the first place, because if that doesn't happen, then the replacement of iron stores may be only a temporary fix. If the person continues losing blood slowly or whatever is the cause of the anemia, then they will probably ultimately end up anemic again. There are some adverse effects to iron supplements, and interestingly, the first thing on your list is not an adverse effect of proper administration of the drug. It is poisoning that occurs because kids get a hold of mom and dad's iron tablets or their multivitamins with iron, and they overdose, and iron toxicity is a real possibility. So these iron supplements are not benign, and they need to be kept out of the reach of children just like all other medications. The iron itself, when taken, even when taken properly, can cause mostly a GI upset. Some people get pretty nauseous when they take their iron. Constipation is actually more likely than diarrhea. And iron supplements will turn the stools very dark, black, even tarry in color, and patients need to be prepared for that because that is kind of startling when you notice it. Liquid oral preparations can stain your teeth. Most of the time, iron supplementation is given in tablet form. And because iron supplements can be given parenterally either by intramuscular injection or IV, when they are given intramuscularly and deposited in the deep muscle, usually using the Z-track injection method, which you'll learn about in a later course, there can be some local pain at the site of the injection. I'll come back to the GI upset that iron can cause and discuss more some of the strategies for managing that. I mentioned that ingestion of iron can cause poisoning, and too much iron can result in iron toxicity. The primary symptoms of iron toxicity are gastrointestinal as well, because the iron is corrosive. It literally sort of eats the lining of the stomach and the intestinal tract and can result in diarrhea and severe bleeding, even potentially proceeding to shock. And though that's not as common anymore, death can occur from iron toxicity. There is, if a poisoning occurs, and I'm thinking primarily of, again, of children who accidentally ingest way too much iron, there is a drug that can be given that to bring about what's called chelation therapy. Deferoxamine, the drug that is used for chelation therapy in the case of iron toxicity or iron overload, it binds with the iron and sort of neutralizes it, and it can be excreted in the urine. I mentioned that iron can be given intravenously, and so I'll talk about a couple preparations which I myself have given to patients. The first one is iron dextran, which is a legitimate iron supplement in parenterally administered, but it has a problem in that it is known to trigger anaphylactic reactions. Not in every patient, of course, but certainly it can occur. Could be so severe as to even cause death. And so, as a result of that, iron dextran is used less frequently now, and it's replaced by ferric gluconate, for example, given intravenously. When iron dextran is going to be administered, a small dose of the drug, of the iron, is given. It's called a test dose because it's much lower than the full supplementation dose, but it's given first to see if the patient experiences an anaphylactic reaction. And of course, anaphylaxis protocol in the hospital would be implemented if a patient did. But if the patient shows no sign of allergic reaction to the small test dose of iron dextran, then they can receive the full dose. So this this iron preparation is given with great care because of its risk of anaphylaxis, although it does restore the iron stores in the body. Ferric gluconate is indicated also for iron deficiency anemia. People with chronic kidney disease undergoing hemodialysis, in other words, they have no kidney function, are one population that's really a candidate for the parenteral iron replacement using ferric gluconate. And this IV iron preparation is much less likely to trigger an anaphylactic reaction. And so test dose isn't used when this drug is given. Now, again, you can see the adverse effects, especially if the doses are on the high end, are GI. The iron is just kind of hard on the gut, and so patients need to be doses are managed to reduce the probability of adverse effects. With that in mind, and I flipped ahead several slides in your PowerPoint presentation to the slides on nursing implication, if people already have some sort of GI disorder, iron is going to be given to them with great care because of the effect on the gut. Remember that liquid iron preparations can stain teeth, and so they need to be properly diluted, in other words, made less concentrated, and drunk through a straw, and that will help to reduce the risk of staining the enamel of the teeth. there's a bit of a paradox with oral iron preparations because they're actually absorbed better on an empty stomach, but because they cause GI irritation, they're tolerated better if they're taken with meals. And so a lot of people just take the iron with meals. Yes, the absorption won't be quite as good, but at least they'll be able to take the medication and get some of it. And orange juice is known to improve or increase absorption of iron, so a lot of people are just instructed to take it with orange juice, but not with milk or antacids because the iron actually gets bound to those and it is less well absorbed. I've already mentioned the fact that iron dextran um, can cause anaphylaxis in people who receive the drug, and so it is a small test dose is given before the remainder of the full dose is given, and you give the test dose and wait an hour. You also want to have epinephrine available and resuscitative equipment in case the person does experience an anaphylactic reaction. We typically call that the anaphylaxis protocol in the hospital, and it is followed when drugs that are likely to cause anaphylaxis are given. And lastly, I also mentioned that when iron is given intramuscularly, it's given deeply into a large muscle using the Z-track method.